Good morning, everyone. My name is Cecile Relo, and I will be presenting my graduate final paper entitled Anaphylaxis Caused by Angiotensin-Converting Enzyme Inhibitors for Dr. Patel Double-Body CRNA 501 Epidemiology Spring Semester School Year 2022 DNP Nurse Anesthesia Program. So today I'm going to be presenting anaphylaxis epidemiology with ACE inhibitors. I will shed some background on hypertension, anaphylaxis, and ACE inhibitors as management for blood pressure. I'll also explain the pathophysiology of this medication and the genetic and environmental factors. Also the research and statistics about ACE-induced angioedema, the current practice of it, and an analysis of ACE inhibitor-induced angioedema and how it's corresponding to the millions of American users. So anaphylaxis has been considered an under-recognized complication of angiotensin-converting enzyme inhibitors. With the increasing prescriptions of the class of medications as initial therapy for hypertension management, the risk of angioedema also increases. Though the statistics result in a small percentage value, the large population managing their blood pressure with lisinopril and other ACE inhibitors dwindles the impact of this allergic reaction and necessitates a further evaluation of its place in the line of hypertension management. So some background about anaphylaxis. Anaphylaxis is an allergic reaction of the human body to an exposed substance or material it detects that may cause physiologic harm. Angioedema, the most fatal manifestation, is the acute swelling of the mucous membranes, such as the lips, the tongue, or the throat, and that could end up with closing of the airway, thus resulting to death from anaphylactic shock. So hypertension is a medical diagnosis that is associated with multiple factors and comorbidities. Its management usually involves lifestyle choice changes with diet and exercise, blood pressure maintenance with antihypertensive medications, which I'll be focusing on. Antihypertensive medications are one of the most commonly prescribed agents worldwide, and these first-line antihypertensives usually include ACE inhibitors, thiazide diuretics, angiotensin receptor blockers, and calcium channel blockers. One popular angiotensin-converting enzyme inhibitor is lisinopril. It is a common first-line drug, and it does have a wide coverage of population as far as chronic conditions go. The likelihood of hypertension requiring medication management in the United States alone is predicted to increase from a recorded 40 million people taking ACE inhibitors from 2008. So the likelihood of this being used a lot more in the future is very likely. Angiotensin-converting enzyme inhibitor-induced angioedema is usually characterized with the swelling of the lips, tongue, face, and intestines, which is often characterized by episodic abdominal pain. There is an absence of itching or urticaria because the presence of it usually mirrors a suspicion of other etiologies. It has already been concluded in a retrospective cohort study that the incidence of ACE inhibitor-induced angioedema is actually larger and actually corresponds and is consistent with large clinical trials with large electronic health records. So in this retrospective cohort study, in a 5-year prescription period, ACE inhibitors have been prescribed to 134,945 people in the outpatient setting of a large academic center. Of that population, 2/3 of them experienced ACE inhibitor-induced angioedema episodes within the first 3 months. 0.07% was within the first month. 0.23% was in the first year, and 0.12% occurred annually and also constantly. In actual numbers, this actually equaled to 888 people that developed angioedema within these 5 years. It occurred a lot more in the age bracket of 60 to 65, and they were more likely to have a history of an NSAID allergy than others. There have also been a number of case reports documenting that angioedema episodes can actually happen after years of stable blood pressure management with ACE inhibitors. There has been one case report of an African-American female, 57 years old, taking lisinopril after 7 years, and then that's when she got that ACE inhibitor-induced angioedema reaction. There's also been a case report of a 64-year-old Caucasian female after taking 2 years of lisinopril, and then a 59-year-old African-American male after 5 years of taking amlodipine, mesylate, and benazepril, which is a calcium channel blocker ACE inhibitor combination. So the possibility of an anaphylaxis reaction, it still remains even after years of taking ACE inhibitors. So we need to make sure that that awareness is there with our health clinicians and also the people that are still taking it. Research has been supported by the National Institute of Health, the Center for Disease Control and Prevention, and the partnership with the National Institute for Occupational Safety and Health. The goal for the research is to define a cause or a genetic factor, an antidote that can override the bradykinin pathways, and then also increase awareness among our clinicians and the consumers from the evidence-based research. The cause of ACE inhibitor-induced angioedema actually lies in the mechanism of action of ACE inhibitors. Bradykinin, an endogenous peptide that increases capillary permeability, also acts as a potent vasodilator and is increased as the angiotensin-converting enzymes are inhibited. Secondary bradykinin metabolic enzymes then come in and attempt to degrade them, but defectively. So those accumulating levels of vasoactive peptides of bradykinin, desARG9BK, which is a metabolite of bradykinin, and substance P further allow for plasma extravasation into the submucosal tissue and therefore leading to angioedema. Research has also found that some physiologic factors and environmental factors actually contribute to that allergic reaction increases with those that are of the female population, those that are older than 65 years old, those of the Black and Hispanic population, and those that have a known NSAID allergy. History of diabetes and obesity also contributes to that, and then environmental factors include irritable fumes, smoking, and seasonal allergies. It has been already seen that ACE inhibitor-induced angioedema actually increases 5 times more in people of the African descent, and it's more due because of the presence of genetic polymorphisms of contributing enzymes that assist in the bradykinin degradation. There have been genetic analyses as well that published one case of 52 cases of angioedema. 14% of those, or 18 subjects of the blood serum collected, actually showed they were ACE inhibitor induced. The rest of it was due to autoimmune disease and NSAIDs and idiopathic reasons. But the conclusion to that was to show that certain genetic coding proteins in the bradykinin pathways are implicit. It is considered prudent for specific healthcare professionals to be aware of this occurrence among patients using ACE inhibitors, even after uneventful chronic use. And when we say chronic use, we think of more than 3 months. The conventional treatment for ACE inhibitor-induced angioedema is more clinically diagnosed just because we do not have any lab values that can confirm it, and we rely more on the medication history of the patient. So when a patient actually shows these symptoms, resuscitation measures are usually involved. There's a standard histamine-targeted allergy therapy, but those have actually been shown to be ineffective with ACE inhibitor-induced angioedema because it actually does not address the bradykinin pathways. As far as conventional treatment, it has already been seen from a 5-hospital emergency department network that 220 emergency treatments were targeted to treat ACE inhibitor-induced angioedema. 128 patients, or 58% of that 220, were sent home from the ED. 27 of them, or 12%, were admitted. 40% or 18% were admitted under observational status or less than 24 hours. And then 25, the rest of the patients, 11%, were admitted to the ICU. There have been antidote trials with the goal of finding one that can provide immediate relief from the hyperinflammation and the avoiding of intubation, tracheotomy, and decline. which can furthermore lessen hospital stays and lessen that severity of that life-threatening complication. There have been a couple of potential antidotes for ACE inhibitor-induced angioedema. Two of them I will be mentioning here. Tranexamic acid, or TXA, has a primary mechanism of action to inhibit the conversion of plasminogen to plasmin, a key step in kallikrein activation and bradykinin formation. Another one is complement 1 esterase inhibitors, or C1-INHs. Their inactivation of plasma kallikrein and factor 12A Hagman factor is thought to modulate vascular permeability, prevent the generation of bradykinin, therefore prevent the accumulation caused by ACE inhibitors. There have been two separate case reports being shown where standard histamine-targeted therapies were given and the effects of the angioedema were sustained. So one case report showed that intravenous TXA, or tranexamic acid, was administered, and the patient's speech and consciousness were notably improved within the next hour, and complete resolution was resolved in 2 hours. Compared to the intravenous administration of C1-INH that was given to another patient, and their angioedema actually resolved after 15 minutes and was further monitored in the ICU. The one thing that they continued to indicate in these case reports was that after that resolution, they of course had to document in the medical records about that ACE inhibitor-induced allergy and replacing that medication that they usually used for blood pressure with something else. In summary, until we have a confirmed antidote that can confirm its effectiveness with ACE inhibitor-induced angioedema, awareness among our healthcare professionals needs to continue. The incidence of ACE inhibitor-induced angioedema by anaphylaxis is increasing. Lisinopril is the third most prescribed medication according to our top 200 medication list from years 2019 to 2020. And there are at least 3 more ACE inhibitors on that same list that is also used for hypertension. Using it in caution with individuals of the African descent, of females over 65 years old of age, and a history of NSAID allergies or a history of experiencing anaphylaxis with other allergens would be good. And then considering substituting those ACE inhibitors with ARBs, or angiotensin receptor blockers, and calcium channel blockers, CCBs, for those prone with this allergy. Special anaphylactic treatments are recommended to still stay close because the addition of tranexamic acid, or C1-INH, to the anaphylaxis protocol for emergency departments would deem effective, and will continue that ongoing research about these medications. Increasing the consumer population of this medication with the increased drug will further urge hospitals, more importantly our emergency rooms, to increase the availability of these antidotes. In conclusion, hypertension is one of the most contributing symptoms to life-changing complications. When the medication relied on to maintain blood pressure are also associated with a risk of anaphylaxis that is showing common, the longer it is also consumed, it is important to identify this risk earlier on in treatment and treat the life-threatening reaction readily should it arise. The effectiveness of these goals will in turn benefit the care provided in the hospital, the health of the affected American population, our communities, and the rest of the world. Thank you very much for listening to my presentation on ACE inhibitor-induced angioedema. If you have any questions, please email me at cr276@evansville.edu. Thank you.